Thank you, James, and thank you, Dr. Crawford, again for the lovely invitation, and Dave Earn and Mark Withersby for putting on the continually excellent conference. So this is a slide from 1989. 1989, Dave Crawford and I and others formed the Prostate Conditions Education Council, which was the first effort to try and do national early detection and screening for prostate cancer. As you recall, PSA had recently come out, and we previously had been relying on digital rectal exam. I'm standing there with our first spokesperson. This is back at Mount Sinai, who was, and Dave, you probably remember this, Rocky Blyer, the running back for the Pittsburgh Steelers, 4 Super Bowl rings, played with Franco Harris and Terry Bradshaw. And over the years, we've had many spokespersons for prostate cancer awareness. In those days, and this was now we got the questions. Okay. How many prostate biopsies? So we're going to have a few questions before I get on with the rest of it, and then I have a post-test question, post-presentation question. So first question. You heard some data today about how many biopsies we do in the U.S. a year, and we're wondering, because of the recent changes from the preventative task force and the decrease in the amount of PSA, has that changed? So how many biopsies, prostate biopsies, are anticipated in the U.S. in 2018? 1.25 million, 1,750,000, or 500,000? Okay, I think I would agree with number one until I show you some new data. Let's go on to the next question. What do you believe the false negative rate is for your first trust biopsy? Is it 10%, 20%, 30%, or 40%? Okay, that's pretty good. Next question. MRI fails to identify multifocal lesions less than 10 millimeters in size, all grades, in diameter, in what percent of patients? 15%, 30%, 50%, or 75%? Less than 1 centimeter in diameter, it misses what percent? So the majority believes it's 30%. Okay, that'll be good to show the data on that. And one more, I think we have one more question. The main reason transperineal mapping biopsy isn't done more frequently because it's inconvenient. It requires multiple inline punctures because of the short specimen length of the current needle we use. There's no mechanism to record the location of where those biopsy sites are. Or you're not experienced, just don't do transperineal biopsies, so you don't really know the answer. Yeah, and I would agree. It's either you're not experienced, it's just too inconvenient to do. Okay, let's go back to the slide. So this was the results of our first 4 years of the PCAW, Prostate Cancer Awareness Week. And what we found was that in terms of examining the patients, 13% came in with a positive DRE. 14.4% had an elevated PSA. And of those men who had a positive DRE, 25% were positive for prostate cancer. And of those men with a positive PSA, an elevated PSA, almost 50% had prostate cancer. Now we know the world is very different today because those numbers are not what represent the current population. But in 1989, 1990, 1991, 92, when this data was put together, we were doing biopsies using a spring-loaded biopsy device, using a transrectal ultrasound, and just about everybody's still doing the same thing. So, used to be that we did have 1.2 million biopsies per year, but the new numbers now are about 750,000. So we've experienced a significant decline in the number of biopsies, and I think we all know why. It's the backlash from the preventative task force. It's the backlash, I think, from patients being told to come in every year to have repeat biopsies because they're on active surveillance. There's a lot of reasons why. And we're trying to do things differently. We're trying to use markers. We're trying to use MRI. I'll show you some of the MRI data. This year we have a decrease in the number of new cancers projected by the American Cancer Society to be 165,000. Last year it was 180,000, so that's about a 10% drop, which probably reflects a decrease in PSA testing and biopsies. But also interesting, there's an increase in the number of prostate cancer deaths this year from 24,000 to 29,000. So trust biopsy is done 95% of the time. It's an office procedure. And the mapping biopsy, which is a procedure that has to be done typically in the OR or the ASC, is only done about 5% of the time. It's done a lot more frequently in Europe and in Australia, but much less frequently in the United States. So this is a term actually that Dave Crawford came up with about interrogating the prostate. So why would you want to do that? Why would you want to know what the pathology is as best as you can in the prostate by a biopsy? And Dave actually said this to me, I don't know, back in the early 90s. You know, if I could just know by biopsy what's in the prostate, we could know what to do. We still don't know an answer to that, but maybe we can come up with a solution. So we want to determine the true pathology. We really want to know what that patient's risk of metastasis and death from prostate cancer. So today we use TRUST, we use MRI, and we put patients on surveillance. And you saw some of the data this morning, about 30%. Some people report as high as 50% of those men who go on active surveillance eventually have active treatment. So if it's 50%, we're not doing a very good job. If it's 30%, we're not really doing a good job. And it's not always because we find worse pathology that we end up intervening. It's also because, and I think it's about half the cases, the patients get tired of being surveilled and worried about going, Laurie's shaking his head, going on.
That's not true, simply not true.
Well, we're not ready for questions. I let Crawford beat on you, but I didn't beat on you. Okay, but you can say that during the panel. Okay, so, and he's right. We can debate the reasons why, but the numbers are true. 30% go on to treatment regardless of why, the reasons there. And to me, that's not the best solution in terms of how we should be managing patients. We'd like to know, I believe we'd like to know the precise location of the tumors. And I think, I don't know for sure, that down the road, there's the potential to make prostate cancer more like breast cancer. We don't take off breasts in the majority of patients anymore. We treat the lesion. So there's the potential, I think, that more than 50% of the patients who need treatment can actually keep their prostates. If we had the information to tell us where the lesion or lesions, you heard from Scott Lucia this morning that the average number of lesions is 2 and 70% have multifocality. So it's the lesions, we can find the lesions and feel secure that we know where they are and that we're adequately treating them. Then we can leave the prostates in most men. So bottom line, TRUST is only positive in 20 to 25% of the patients. 30%, that was one of the answers, need a repeat biopsy because of false negatives. I think it has limited usefulness for selecting patients for active surveillance. It really can't be used for focal therapy because we're missing too many lesions. But it's hard to change what we do because we're very comfortable what we do, and it's going to be a big job to get people to switch over to something they're not familiar with, and we're going to need to prove that it actually has a benefit. So here's some of the MRI data this is from UCLA, from Lenny Marx's group, and this is another one of my questions. MRI misses 73 to 89% of lesions smaller than 10 millimeters. And this is based on radical prostatectomy whole mount sections compared to the MRI. And even if you're saying, okay, forget about those Gleason 6s because they don't show up very well in MRI, and you're focusing just on the 7s and 8s, it's still missing 29 to 38% of the multifocal lesions. Here's another paper out of the UCLA group where they were looking at the ability for the MRI to determine the lesion size. So on the left, you see the whole mount and the prostate cancer circled in red. On the right, you see the corresponding co-registration between the whole mount and the MRI and the lesion on your left there on that first image. That's pretty good concordance. You could build a 1 centimeter margin around that lesion and say, I got it. But look at the lesion on the left on both images. If you built a 1 centimeter margin, you're going to be missing the boundaries of that lesion. So MRI, and this is well known now, does not define really well the borders of the lesions when you relate them to the whole mount prostatectomy specimens. So how big do you make your ablation if you're going to do targeted focal therapy using MRI as your indicator of where the lesion is? What about active surveillance? Here's a paper, again, it's from the UCLA group, where they did an MRI. They selected patients for surveillance based on the MRI's results. So those men with negative MRIs didn't get a biopsy, went on surveillance. They repeated the MRI and redid the biopsies a year later, and 30% of the patients had upgraded disease, which probably means that 30% were missed, which is the same 30% I showed you before on what does MRI miss. With Gleason 7s and above, it was 30%. And lastly, here's a new paper out of NYU, because everybody should know that Samir Taneja is there, and they have got some of the best MRI units in the world, and now using 7 Tesla units. And what they did is they took patients, used the MRI to find the lesion, so the index lesion, and then they planned out a focal therapy based on the MRI, and then those patients went and had radical prostatectomy. They didn't do the focal therapy. And when they looked at the field that they would have ablated with the MRI-guided focal therapy, they found, again, looking at Gleason pattern 4 and above, they would have missed 49% of the lesions because they were out of the planned focal therapy field. So yes, MRI has helped us, but it's not the be-all, end-all, and people will get led down the wrong pathway if they start doing things without recognizing the limitations. So what about transperineal mapping biopsy? So this is my colleague with one of my former fellows in Athens, Greece, doing a transperineal mapping biopsy. You can see he's using a brachytherapy grid. He's putting the biopsy needle through the grid. He's looking at the ultrasound image, and you can make out the little white reflection of the needle going through the apex, and it stops halfway through the prostate. So this is what we do today. This is what Dr. Crawford's been doing probably for 15 years now in his practice. I was doing it at Mount Sinai in my practice because I was using this to look for patients who had failed brachytherapy and they had slow-rising PSAs, and I was getting no results for transrectal biopsies. So for me, moving from the transperineal brachytherapy to transperineal biopsy was an easy transition. So when I moved to Colorado in 2012, I got together with Dave, Scott Lucia, and other members of the group because we were like-minded in doing the transperineal biopsy. And Dave had been worked with the pathology predecessor to Scott Lucia, Gary Miller. And if you remember, the year after we had that first Prostate Cancer Awareness Week, that was the year of your first meeting in 1990, which both of us were at, and Bob Donahue, I think, the 3 of us. So I got together with the group, and we sat down, and we said, we love the way transperineal biopsy is done, but people are not going to do it for all the reasons you could see here. The biopsies take too short a specimen, and they deflect. So if it's moving all over the place, how are you going to know where you're at? There's no real good software to record the location of every site within the prostate you want to biopsy. And if you were able to take a longer biopsy, what would you do with that tissue if you needed the pathologist to look at it and it had to be delivered to the pathologist intact? Because most of the time the tissue comes in pieces. So if you're looking for localization information along the core, you're not going to get it. So that was a challenge we faced, and we brainstormed back in 2012, what do we need to do to try and help solve this problem? So the first thing we did is we pulled this article by Kepner and Kepner, 2010. What Kepner and Kepner said was, if you could drill holes in the prostate, and those holes or biopsies were a certain distance apart, and they were a certain size, you could define the size of the lesion that you would miss within the gland. So that math translates out into, if you took a 15-gauge needle and you did biopsies at every 5 millimeters, the spacing that you would not sample would equal 3.5 millimeters. So that sounds pretty good because that's pretty small. So there's going to be a question at the end about that. The next challenge. So here here's the software in its early design phase. So you see the representation of the needle is straight. And this is no different than the representation you would see with an MRI fusion software. But look what's happening to the needle. It's bouncing above the representation. And if I want to record the exact location of the needle, because I want to find a Gleason 8 prostate cancer that's 0.3 cubic centimeters. I can't have that needle bouncing all over the place. So we had to figure out how to fix that problem. And the other problem we needed to fix is when you use your standard biopsy needles in the office, and it's got a 20 millimeter or 2 centimeter core bed, the average length you get of a specimen is 12 millimeters. That's 60%. And there's a fair amount of data that's here. It's one of the papers that says when the length of the core is more substantial, you increase the diagnosis of prostate cancer. But we had another reason and that is because if we want to take a longer biopsy, if we don't get the full length of the core, we don't know what's in the tissue that's missing from that core. So that was another problem to solve. So the first problem we addressed by looking at the way the typical needle, which is lancet tip, bounces around when you fire it into a jelly that reflects the density of the prostate. So on the left, you see your barred needle and the deflection. We eventually came up with a 4-point trocar tip needle that has 1/9 of deflection, which is 0.1 millimeters of the barred needle. So we solved that problem. Then the next problem is, how do you get that 60% to 100%? So we figured out that if we put these ridges in the needle, in the core bed, as the cannula slides over the needle to cut the tissue and push it into the core bed, instead of the tissue sliding along that core bed, it's going to be held in place. And that's exactly what ended up happening in the lab. When we tested this needle between 20 and 60 millimeters, you could get 95% of the tissue you wanted. So now we have a needle that can take a specimen between 20 and 60 millimeters. So whether you're doing a truss fusion biopsy and you've got a lesion that's anterior, or you can put this in the rectum into the posterior capsule, dial the distance, and take a biopsy that spans 5 centimeters if that's what you require. If you're doing a transperineal biopsy, you can take one biopsy from apex to base regardless of where you are in the prostate as one core, not do the multiple sticks. So we made it simple, so that's what the needle and the insertion tool looks like, and that's what the biopsy device looks like. And lastly, say you could take a 5 centimeter core. What are you going to do with that tissue? Because you've got to get it to the pathologist so they can look at one end, call it the apex or the anterior capsule, and look at the other end and tell you where on that tissue the cancer is and how long it is. So if you're doing what we did, this was back in Greece, picking up the specimen with the needle and dropping it into a vial of formalin, that's what they do at the University of Colorado with the forceps. There's no way Dr. Lucia is going to tell Dr. Crawford what's going on in that full length of tissue. It's not happening. So we had to come up with a device that would manage the longer specimens. And this is what it looks like. This is a woven polyester fabric impregnated with proprietary chemicals. That's a 6 centimeter specimen out of cadaver with our needle, showing how it lays on the device. The lower specimen shows you close the device. That goes into formalin. It goes to pathology. It gets cut in half, because remember, the cassettes to process these specimens are only 3 centimeters long. So they stain one end, that's the base, one end the apex, another color. They cut it in the middle. They lay the 2 pieces in the processing cassette. It goes through all the steps of processing and dehydration, paraffin impregnation, sectioning on the microtome, staining, and being read by the pathologist. So now we have a mechanism to protect the specimen. If you're looking along that specimen and you're going from one end to the other, the pathologist is going to tell you that, okay, the cancer starts at 2 centimeters, it goes for 1 centimeter, and there's no more cancer. He gives you the grade and the length of the tumor, its location. It gets backloaded up into the software, and then you're ready to go. So this is the prototype software that's being used in a phantom. This is not used in a patient. So we had 3 lesions, simulated lesions, that we found in this phantom of the prostate. So then the question is, just like with the MRI, how big is that lesion? Because all we know is that we've got a biopsy that goes from base to apex, but we don't know the diameter of the cancer outside of the lesion. So the way that I figured out we could determine that is if you have all these blue needles around it that have no cancer in them, then the theoretical diameter of the cancer could extend out to the next negative needle around it. So now that's what I've done here. I've simulated this. There's a tool in the software that allows you to grow the circumference of the cancer. That information then can be exported in DICOM, and then you can marry that real time to any type of treatment planning system for doing focal therapy. This also puts the onus on the urologist, because I'm telling you 5 millimeters. But the real life is, if you've done brachytherapy, you know the needles never end up in the exact same place. So if you've got needles that are 7 millimeters apart or 1 centimeter apart, you've got the record on the post-biopsy file. You grow the lesion out to that next negative needle, and that's your zone of ablation if that's what's appropriate for the patient. So in conclusion, 3D transperineal approach utilizing software designed with a new gun and needle has the capability of detecting lesions as small as 3.5 millimeters. Can this platform serve as a virtual prostatectomy? Interrogate the prostate, Dave? I think it does, but we need to prove it clinically. That's to come. When we decide to do targeted focal therapy, that's going to be another issue. Do you want to target Gleason 7s or you want to target Gleason 8s? What happens if you had a 0.2 cubic centimeter Gleason 8 in the prostate? Do you need to take that prostate out? Or can you just ablate it and leave the prostate in? And of course, we have to demonstrate proofs of concepts, and these devices are not approved for clinical use.